Okay, we're now live and recording. I'd like to welcome everybody back to the Metabochondriacs, co-hosted by Brett Smith and Dr. Ryan Cooley. And today's topic is going to be, I know near and dear to a number of people that I know personally and even some of my coaching clients. And it has to do with how insulin resistance and what we call visceral fat, that it can also be called atopic fat, but when we start forming fat in our rib cage, in and around our organs, such as fatty liver, fatty pancreas, and things that can happen where we're accumulating fat inside of these organs. But Dr. Ryan Cooley is going to elaborate on what he's been seeing in his practice regarding insulin resistance and what these fats on top of the organs and the arteries represent from a risk factor, not just a risk factor, but actual damage that's being done. So Ryan, let me turn it over to you and take the ball and run with it.
Hey Brett, let's talk about ectopic fat and cardiovascular disease, but let's start with atrial fibrillation, which is obviously something I see a lot of in my practice. When we talk about atrial fibrillation, we talk about it, pathophysiologically. What is the genesis of atrial fibrillation? We talk about it from the perspective of risk factors. These are things that associate with a higher prevalence of atrial fibrillation. Things like high blood pressure, alcohol abuse, sleep apnea, valve diseases. Diabetes is listed there as well. And there's data. It's not robust data. There's data going back to about, I think, 2010 up to about 2020, and then you just don't see anything more after that. These are observational studies linking insulin resistance specifically with atrial fibrillation. So we know that insulin resistance and diabetes associates with it. Interestingly, when you look at the evidence base regarding the impact that reversing some of these risk factors have on progression or incidence for that matter, there's only a couple things that work. Weight loss for sure. And so, you are tying into that ectopic fat probably, and that ectopic fat is contributing to AFib, and your people who undergo greater than 10% of their a loss of 10% of their body weight have a significant reduction in AF burden and can even have reversal. They're probably just losing ectopic fat. And we know that ectopic fat associates with insulin resistance. Alcohol is another one. Abstinence of alcohol. When AFib is felt to be secondary to or contributed to by alcohol, abstinence has about a 30% reduction in AF burden. But treating blood pressure and doesn't in the clinical studies, interestingly. And treating sleep apnea is kind of plus and minus. There's a meta-analysis of some small studies that showed treatment had a benefit, but there's bigger RCT data that said that treatment of sleep apnea didn't help. And it kind of.
Can I do a quick jump in here, because there's something you just touched on that we haven't talked about this ever in this capacity, but when you just mentioned that blood pressure did not impact, my guess, and again, I'm just taking a shot in the dark based on what you just said here, is the blood pressure was probably most likely resolved or managed down through medication. It wasn't that the person just no longer needed medications and resolved their blood pressure at a root cause level. Is that a fair assessment? Is that a somewhat correct statement?
That's exactly correct. I mean, that's what kind of led me to be thinking about root cause, because treating the sleep apnea in RCTs didn't reduce AF burden. And treating blood pressure pharmacologically didn't do it either, even though high blood pressure associates with increased incidence of AFib and progression.
But that makes just perfect sense, though,
Right.
as you now see everything through metabolic lenses, that instead of putting somebody on a CPAP as a symptom and keeping them from stopping breathing 60 times an hour and putting somebody on a med, you're not getting to the root cause of what's causing everything. So by doing those types of things, you're not ever making the impact. But somebody loses 10% of their body fat and is no longer insulin resistant and no longer has, and you're going to talk later about showing the fat on the organs. That makes radical. Okay, I'm glad I caught that correctly. Anyhow, go ahead, keep up.
So we are looking at insulin resistance because it's obviously a marker of visceral fat. And it's significantly underdiagnosed because, I've talked about this before. It's based on glucose-centric metrics, which have pretty significant limitations. So we are looking at the prevalence of insulin resistance as diagnosed by HOMA-IR, which was the metric that we chose to look at, in a unselected AF population in my clinic. And the data, we haven't published it yet, but we're still accumulating some of the data. But the data is really incredible so far. I mean, it's well over 90% of our AF population are insulin resistant. And when you look at the studies on weight loss, what you see is that there is reversal of some of the damage that the ectopic fat is doing. And maybe you can throw up that first slide. What we see with regards to ectopic fat is that the fat actually infiltrates into the cellular anatomy, and it distorts the anatomy, it distorts the architecture, which directly disturbs the electricity flowing through the cells. It creates heterogeneity of, impulse passage through the cells, which is a contributor to arrhythmia genesis. So this is kind of a summary, really, of the impact that in this particular review, it was termed ectopic atrial fat, or EAT. So they're showing you, where the fat accumulates, and it accumulates around the coronary arteries, and we'll get into that as a root cause for atherosclerosis. And it accumulates around the left atrium, specifically where the veins attach to the back wall of the atrium, which is where atrial fibrillation originates in the vast majority of people. So we have an anatomical correlation, and there's also then well-described functional abnormalities. So, this slide kind of highlights, what's going on. There's fibrosis. So there's signaling for fibrosis or scar tissue. So not only do you get distortion of the architecture and the cellular connections by scar tissue, but the fat, as I said, actually infiltrates. It's like it's its own organ kind of snaking through where it shouldn't be. There's inflammatory signaling cascades where you have these pro-inflammatory cells, like pro-inflammatory macrophages that are secreting inflammatory, what are called cytokines, things like interleukin-6 and TNF-alpha. You have adipokines.
I don't know if your video just froze there, but you haven't spoken in a couple seconds. There, you froze for a second, Ryan. Your connection went out. So
yeah,
you were saying that you said adipokines and then paused for like 15.
Adipokines adipokines are reduced. So the production of so the inflammatory adipokines are increased, but the good adipokines like adiponectin is reduced. And you can think of adiponectin as nectar, right? Nectar, kind of similar. So adiponectin is like the nectar of metabolic functioning. So you want more adiponectin. And I'm actually having trouble reading this darn thing myself here. So when you and then you have they actually can look at how the electricity flows through the cells, and you see patterns of electrical flow in this environment that is very pro-fibrillatory, without going into too much depth there. But it all makes sense that this is really a very powerful root cause, and it aligns with the insulin resistance syndrome. And weight loss can actually result in, or I should say, I hate using the term weight loss, right? Because we use weight and we use BMI, and it's really about visceral adipose tissue, and that's what's causing a lot of problems. So when you have the environment for the displacement of adipose tissue in and around the heart, you're really promoting the two of the major cardiovascular diseases that we see, which is which is atrial fibrillation, and then atherosclerosis. And that's why when I did the podcast with Phil Ovadia, I talked about AFib as being a metabolic disease, and I think that it largely is, with greater hazard ratios compared to other risk factors, for sure.
Absolutely. It's really amazing how it tracks, because it just makes perfect sense. Some of the deep diving I've done over the last few years regarding visceral fat and what happens, some of it is what I've learned from Dr. Sean O'Mara and his channel, and he goes heavily into this because he did MRI scanning on the abdomen and thus the visceral fat of what's going on with thousands of patients. And every time that the visceral fat wiped out, everything went back to normal. And, so just as you're saying, this fat is sitting on the organs, it's sitting on the arteries, it could be even inside of the liver or the pancreas because it's not able to clear it out. And they, for layman's purposes, they excrete, they ooze out these negative compounds, these interleukins and cytokines and such that do damage. And so, but this is not really ever taught in medical school. There's not the new doctors coming out that are saying, oh, Dr. Cooley, it's this. I mean, you're still finding this after 20, 25 years in practice, as you're now looking at everything through a root cause and metabolic health filter.
Yeah. The one thing I wish we had to add to that is imaging, right? It's just hard to get imaging covered by insurance plans. So that would make everything even more robust, because as I said, it's all about the visceral adipose tissue, and quantifying that would be very powerful, using some sort of imaging technologies. But it's just hard to get that covered.
Absolutely. Well, and then it's also hard to have the radiologist know what they're looking at, because that's the other thing that Dr. Sean O'Mara talks about is he goes, do you see all of this right here? And the radiologist is like, yeah, what is that? Because they never read it. They never talk about it. And he goes, well, that's the visceral fat and, in and around the organs. Oh, does that mean anything? Is that important? And
that's a hugely important point you just made, because a lot of our patients with atrial fibrillation or coronary disease are getting different types of scans for different reasons. They might be getting a CT scan.
Yeah.
They might be getting a pre-ablation, which is a interventional treatment for AFib, MRI image to look at the anatomy. And you never see the radiologist talk about the fat. And when I do procedures on patients and we look under ultrasound, we invariably see a large amount of epicardial fat on the outside of the tissue. You can see it on ultrasound. So we have these really nice images, and you're like, holy cow, that's a lot of fat around the tissue. And we always look at that because we want to get a pre-treatment view of the heart, so that if a complication arises, such as bleeding, you're able to detect the difference from the pre-treatment images. But it's to me, it's always striking how much epicardial fat there is. And not only do we see it, along the atrial wall, but we see it along the ventricle walls, right? So, again, that's the segue we'll take here into coronary, to the coronary atherosclerosis and the root cause of atherosclerosis. And you can see on this. Why don't you go to the next slide once? So this is arrhythmogenesis. Again, so it's just kind of a little bit more detailed. It kind of gives you the different layers. So you have all that ectopic fat on top. You see the inflammatory macrophages, the mediators of inflammation that they're secreting. You see the signaling pathways for fibrosis. You see the disturbance in the continuity of the muscle cells as you get into the atrial muscle tissue. Can even disturb the autonomic, which is the nervous system signaling to the heart, which could have some implications for arrhythmogenesis as well. And then go to the next slide. So regarding coronary disease, it's a lot of the same thing. It's you have this pericoronary fat tissue, and it's all disturbed adipocytes with a lot of inflammatory mediators. Again, the inflammatory macrophages and all these signaling cascades, which disturbs the endothelium, which is the cell lining, and so you get endothelial damage, leaky endothelium. You get disturbances in lipid metabolism. You actually get, lipids being deposited into the cell wall epicardially, and not from the lumen of. We always talk about, everyone talks about lipid particles in the lumen of the vessel leaching into the wall from the lumen side. Hardly anybody talks about lipids coming in from the epicardial surface.
Yep.
And so again, you just see these inflammatory effects, lipid infiltration, both sides. And this is in the milieu of a systemic lipid metabolism disorder. So you've got lipid particles that are elevated because the liver is also experiencing the effects of liver fat and excessive energy toxicity. When you get energy toxicity, when you're not burning it or storing it very well, it's going to the liver. You get lipogenesis, you form lipids. The lipids are often abnormal, so they get more easily damaged under oxidative stress environments. They almost represent an antigen, which is a foreign particle, a foreign signal to the immune system. Right? They're not normal. So they're actually it's a form of autoimmunity. Our immune system is part of this cascade of atherosclerosis. And it's recognizing these abnormal lipid particles as foreign substances, it's like a bacteria.
Can I jump in one more time?
Yeah.
And again, we didn't talk about this aspect of it either, but just again, as I'm listening and watching and learning, but also correlating to both other things that I've learned about the visceral fat and what it does, as well as think back to when we did our Zoom call and you got your first pulse test results and I got my year-over-year results. And then think of the year where I dropped, just before my first one, I had just dropped 115 pounds in 9 months. So the amount of visceral fat that was pulled out because you might remember Dr. Harrington's, he told me on my first year results before you came in, well, Brett, I can see that you're healing. So whatever you're doing, keep doing what you're doing, because the pulse test has the ability to show whether there's disease progression or regression, thus healing. And then and if you remember, I don't know if you actually physically remember though, how shocked he was. He goes, well, Dr. Cooley, let's show Brett's results because it's year over year and you're going to learn more by seeing 2 different years and a change here. But then he turns to me and he goes, Brett, what have you been doing the last year? Because that 85% reduction in soft plaque is a measurement of what's going on from these cytokines and everything linking in, and the macrophages that the pulse cardiac measures these markers explicitly of what's going on. And it makes perfect sense that, oh my God, well, I lost a great deal, probably 90% of my visceral fat in that first year, kept it going in the second year. And that's what we're really seeing as a result of the tremendous improvement that I had in year over year. Does that sound like that correlates, that's in line with what you're thinking here?
Yeah, absolutely. And I mean, I think they're the only company too that has that really novel testing to include, these markers of inflammation. And I was just going on my cell phone here to pull up my spreadsheet that I have with all the stuff that they measured, IL-16, MCP3, eotaxin, immune activation markers. I mean, really novel stuff.
Everything you were just talking about is right in there.
Right. And it's never taken off, right? Because, conventional medicine be like, what the hell's that? Right. It's not LDL, so we just can ignore it.
It would have taken, it was just COVID that killed it, because doctors weren't seeing patients. True. They're not going to see a rep. So
true. Yeah. But I think this is also very interesting when you look at the data. And I didn't pull this in here as a slide, but there is a study that looked at the relationship between visceral adipose tissue, just in general, that in quintiles to total plaque volume. And you saw massive increase in total plaque volume, 5 to 6-fold higher plaque volume when you go from the first quintile of that to the 5th quintile of that. Depending on gender, I think males was 5 something and females was 6 something. So it's, and I think about that data when, Nick Norwitz and Dave Feldman and Adrian present their data. And I haven't really looked at or listened to this too much, but I know that I've caught some wind of some of their preliminary data in the lean mass hyperresponder. And what they're showing is that total plaque volume has no correlation with any lipid metric, right?
True.
And it's such an interesting population from my perspective, and I think it should be from every cardiologist's perspective, because it's the first time we've been able to completely uncouple the confounder of insulin resistance and poor metabolic health with elevated lipid and genetic too. Uncouple that. These are not genetically abnormal patients. They are not insulin resistant patients, but yet they have high LDL. And total plaque volume doesn't associate with any lipid metric when you are actually able to uncouple them. There isn't a single prospective study, to my knowledge, where we've been really able to uncouple that confounder.
Yeah.
It exists because we know that 93% of the population is not metabolically well, and we don't measure it in these studies. We measure diabetes, but we don't measure insulin resistance.
Let me jump in with one more, mainly for the audience here, because again, we have different kinds of adipose fat tissue in our body. There's the brown fat, which is nothing but great for us. And babies are born with a lot of brown fat. That's how they're able to stay warm and survive, being just little babies. Then we have subcutaneous fat. And even when you're metabolically healthy and a thin person, you're going to be somewhere in typically the 10 to 20 to 24% body fat percentage. And that's functional fat. That's used for constant energy because the glucose just doesn't stick around, and we don't have a way to do. That's why when you hear people like yourself who like to do long bike rides and marathons and triathlons, or even just a whole day of tennis tournaments, you hit the wall. You've just ran out of your glycogen supply, and you're not adapted to burning the fat. And now you're stuck. You got nothing going on. But where I'm going with this is that that's normal, healthy fat that we've always had on our body. The visceral fat is coming from the processed junk foods, the excessive alcohol, and all of the things that we know are not good for us. Those seed oils and everything, they just come and they immediately go here. They don't go to your adipose. Some can go to your adipose tissue, your regular subcutaneous fat. And this is what Sean O'Mara is brilliant. Dr. Sean O'Mara in his YouTube channel is just brilliant in demonstrating, because he's just like, go as low carb as you can, have fermented vegetables, the sauerkraut, the kimchi that you and I both do all the time, the kefirs. But then he also is like, and regardless of your age, there's a way to do it. But he's like, all of your exercise should be sprinting. And if you can't run, just get on a bike and do a HIIT program where you're hitting it hard for 30, it might only be 15 seconds initially. And then you go slow for the next minute or two, recover, and then hit it again. And you just build up the tolerance. But this is why I go outside and I do sprinting. And I'll sprint as much of 100 yards as I can. I walk 100 yards, sprint 100 yards, walk 100 yards, because the combination of going very low carb as well as the high intensity sprinting HIIT type training is what melts that visceral fat out the quickest. It's usually the first stuff to leave, but it should be, and it's the most therapeutic fat to leave. Anyhow, I'll just throw that out there and see what you want to say about that.
Yeah, exactly. I mean, when we're neonates and in early years of life, the ectopic fat around the heart is morphologically and functionally very similar to brown fat. It is cardioprotective. It provides an energy source to the rapidly growing, infant, and it's thermoprotective. But as we age, we lose that thermogenic function in the fat cells, and as we accumulate this abnormal fat, especially under in the environment of pathological conditions, the fat cells actually express genes that encode for profibrotic states and what's called apoptosis, cell death, right? Mm-hmm. So the fat cells are actually expressing genes that are pro-atherogenic and pro-arrhythmic. So very different than the fat that's around, the infant and the, rapidly growing adolescent.
So what you're seeing here in your specialty on the heart, the nephrologist, if they're focusing on what that fat is doing on the kidney compared to the liver doctor, is looking at what's happening there. But I don't see anywhere in healthcare that we're all talking, one, that they're really acknowledging yet that this is happening, and two, that we're saying the body's a system. And this just happens everywhere that it is.
Yeah, exactly. It's happening around all the organs. So it's liver dysfunction and altered lipid metabolism. It's pancreatic dysfunction. The fat. It's Roy Taylor's twin twin cycle hypothesis of diabetes, both liver and pancreas. And, that has got some play. I mean, I think people are starting to tune into that, in the metabolic diseases arena, in endocrinology and so forth. But cardiac, what, man, nobody's talking about ectopic fat and the influence that has on, as I said, both coronary atherosclerosis, proatherogenic and proarrhythmic atrial fibrillation. It's the most common arrhythmia that I see.
Well, I'm going to ask a quick question of you, being the expert that I am not. I know somebody who has been talking to their cardiologist, and they're planning on doing, and I'm not sure of exactly why the spacing, but they just 2 weeks ago had an appointment, and they're saying, hey, if things don't improve, we're going to do an ablation in spring. So really kind of giving this person 7 months to pretty much get on top of things. So would your guess be that if they are able to tremendously reduce that visceral fat, that there's a chance that they could possibly not even need the ablation come spring?
Yeah, there's always that possibility. I've seen some pretty significant reductions in AF symptoms and burden, such that they wouldn't necessarily need an intervention. But it's very individualized, and it kind of just depends on the stage, right? If you have somebody that is really suffering, I don't know that it's even though lifestyle modification and loss of visceral fat will help, I don't know that you would necessarily avoid the intervention.
Because there could still be enough damage there that
Yeah.
you still need to have things done.
Yeah. And it may not all be reversible. So I think that these procedures can help sort of manage things that aren't going to improve. But we do know that it's important to pay attention to the lifestyle piece as well, because the outcomes of ablation are vastly improved in people who improve their overall health and reduce their root causes. So it's really a two-pronged. In many patients, it's a two-pronged approach. If you have somebody with atrial fibrillation that is pretty infrequent, they're in the earlier stages, even if they're pre-atrial fibrillation, that's the biggest bang for your buck with lifestyle is going to be in the earlier stages, right? Because those are going to be very likely reversible to a large extent, and reversible enough that they don't get clinical problems. So they've staged the AFib, differently now, where the focus has started to shift towards the lifestyle modification piece, because they're staging atrial fibrillation when, number one, like stage one is there's just risk factors only. No structural or electrical change has occurred yet, but just risk factors. And stage two, they have risk factors, but they also have evidence of structural or electrical abnormality. And they may have pre-atrial fibrillation arrhythmias where if you did a monitor, for example, you would see some extra beats occurring in the atrium, and maybe they might have a series of extra beats in a row. Not enough to call it fibrillation. Most people use about 30 seconds of arrhythmia to say, oh yeah, the atrium is fibrillating. And then you get people who have still they actually have atrial fibrillation, but it's still pretty infrequent. And I think those are the patients that, definitely can probably, with successful lifestyle modification, avoid a procedure.
Excellent.
There's always, and no matter what stage you're in, lifestyle modification is paramount. It should be primary.
It's the major thing that can change everything.
It should be primary, because even if you're in the later stages and you need an ablation, that outcome is going to be far superior if that person manages their risk. and they're not just treating a symptom, but actually treating the root cause disease process.
Absolutely. Well, I think that's a heck of a nice little talk. Is there anything extra that you would think we would be remiss by not throwing in, or does that kind of do a nice,
Yeah, I think we should be sensitive to the time. We're at 35 minutes, so I think
Yeah.
it's good. I think we covered it pretty well.
Okay. Well, I'll just quick do a circle back. The visceral fat that we are putting inside of our rib cage and on our organs and inside of our organs at sometimes is a major driver of the dysfunction that's happening within these organs. You get rid of this, which can be done. It's reversible. We just talked about how with my weight loss, it happened, and we could measure it by measuring those interleukin 6 and 16s and cytokines and everything that I had in that pulse cardiac test. So everybody, it's about what we're putting in our mouths, and it helps to be active. Doing some form of aerobic and HIIT type, sprinting type stuff will work. But that's why I always focus on that and lifting weights as opposed to the long distance stuff. I'll leave that there.
Yeah.
So, okay.
No, I think that's good. And I think we should also mention it's not just nutrition, right? And maybe one of these next podcasts we're gonna go into and branch out a little bit, right? Nutrition is probably the biggest lever you can pull, but there's obviously other things, right? I just read something that would be near and dear to your heart, that infrared light exposure has an effect on mitochondria that improves glucose regulation, right? There we go.
And improves ATP output by about 30-40%. Yeah. So anyhow, well, let me just touch on in under 10 seconds. There are kind of what people would say 5 pillars to all of this. So yes, the diet is part of it. How you manage stress. If you're a stressed out individual, figuring out how to manage that stress is going to be critical. Doing some resistance training and some sprinting type stuff. But even in my pulse cardiac sales rep manual, it was the HIIT training, the sprinting, and the resistance training was the key, and that's all I focused on. And then sleep is absolutely incredible, and obviously just being a happy person. The more social interaction you can have around you, managing that stress, managing that food, those are the 5 pillars right there. So we'll dive more into all other aspects of this. Everybody, thanks for joining us. We might make this our shortest one, close to maybe what the last one was too. So thanks everybody for joining us, and we'll see you again very soon.